Welcome everyone to our September clinical update on designer benzodiazepines. This is a copyright slide just to let everyone know that the following material is not authorized for reproduction without express written permission. Thank you for joining us today for today's webinar. My name is Kristin Hillman. I'm a member of the clinical team at Aegis Sciences Corporation. This is a brief educational webinar examining designer benzodiazepines. The objectives for today are to be able to understand how the use of designer benzodiazepines has changed over time and how recent regulations have played a role. We will look at different types of drug testing and where there might be some confusion. And lastly, we will review data from Aegis that may point us in a direction to those who may be most likely to use designer benzodiazepines. Those who missed the live presentation or would like to hear it again may find a recording of this presentation at the Aegis website at www.aegislabs.com. Please call 1-800-533-7052 if you need assistance accessing the recording. Designer benzodiazepines represent a major public health issue, and their prevalence has increased substantially over the last decade. Slight alterations of chemical substituents at various positions of a benzodiazepine molecule can yield a large number of different designer compounds. These designer drugs may possess less or greater effects when compared to a prescription benzodiazepine, and evidence suggests that these substances are being used non-medically for their sedative and hypnotic effects. Adverse reactions, which are similar to known benzodiazepines, include CNS depressive-like effects, such as ataxia, altered mental state, respiratory depression, and death. From April to June of 2019 to April to June in 2020, prescription benzodiazepine-involved overdose deaths increased by 22%, and illicit benzodiazepine-involved overdose deaths increased 520%. Other risks involve the concurrent use of designer benzodiazepines along with other prescribed or illicit drugs. During January to June 2020, 93% of benzodiazepine-involved deaths also involved opioids, and 67% involved illicitly manufactured fentanyls. The increasing illicit availability and prevalence of designer benzodiazepines is of concern and has been gaining regulatory attention. Between 2010 and 2015, the first true designer benzodiazepines were identified that had never been licensed for medical use anywhere in the world. And by November 2018, at least 24 different designer benzodiazepines had been identified. A trend highlighted in a study of the National Poison Data System reported a 330% increase in designer benzodiazepine exposures from January 1, 2014 to December 31st of 2017. According to the Center for Forensic Science Research and Education, which is a nonprofit organization in collaboration with the Department of Justice and Centers for Disease Control, between 2020 and 2021, etizolame was the most identified designer benzodiazepine, identified in just over 1,000 toxicology cases, many of which were co-identified with fentanyl. In October of 2022, the DEA announced they would place 5 designer benzodiazepines, including etizolame, flualprazolam, clonazepam, flubromazolam, and diclazepam on temporary Schedule 1, all meeting the specific criteria outlined for Schedule 1 and ultimately posing significant risk to public health. In Q2 of 2022, etizolame and flualprazolam started to decrease in positivity, and by Q4 of 2022, bromazolam started to become strikingly more prevalent. The dramatic increase in bromazolam circulation could be a result of this escalating pressure from the DEA. The temporary Schedule 1 for the 5 aforementioned designer benzodiazepines officially went into effect on July 23rd of 2023. Bromazolam, the brominated counterpart to the chlorinated drug alprazolam, was first synthesized during medicinal drug development in the 1970s, but it was never approved for therapeutic use in the United States. Bromazolam first emerged in the recreational drug supply in 2016 in Europe and in 2019 in the United States, and has been linked to adverse events resulting in hospitalizations and death. It is commonly reported in combination with other drugs, including fentanyl. The Q3 drug checking report from the Center for Forensic Science Research and Education showed 2 samples that contained bromazolam between May and September 2022. The first sample contained bromazolam in combination with fentanyl, xylazine, 4-ANPP, and flubrorazepam. The second sample was bromazolam in combination with fentanyl, xylazine, 4-ANPP, caffeine, and procaine. A case report from the University of Nebraska Medical Center describes a patient requiring hospitalization for withdrawal from a combination of phenibut and bromazolam. This patient had obtained bromazolam as a means of self-treating his insomnia caused by long-term phenibut use. Out of just over 212,000 samples collected at Aegis from June to August of 2023 were tested for both benzodiazepines and designer benzodiazepines. 196,969, which is 93% of those, were without a benzodiazepine indicated as prescribed. Those without prescription access to benzodiazepines may be more likely to seek out non-prescribed benzodiazepines. When we compare the detection of designer benzodiazepines in individuals who are not prescribed a benzodiazepine versus those who are prescribed a benzodiazepine, it is 10.6% to 1.37%. The detection of designer benzodiazepines is significantly more frequent for individuals without a benzodiazepine prescription. While these figures may seem daunting, it is still an underrepresentation of actual positivity, as many samples received at Aegis do not include medical orders for NPS testing. It is of vital importance to understand and utilize this data as we continue to care for individuals in this current environment. Some publications have demonstrated designer benzodiazepines as unexpected positive results in immunoassay testing. When these samples are sent for confirmatory testing to a lab that only performs routine testing, the designer benzodiazepines may not be detected. These clinically confusing results could easily be dismissed as an immunoassay false positive, and the individuals may not get the attention needed from having ingested novel psychoactive substances. Aegis launched an extensive and industry-leading testing menu of novel psychoactive substances in mid-2020, which includes designer benzodiazepines, designer opioids, synthetic cannabinoids and stimulants, hallucinogens and dissociatives, xylazine, tianeptine, and phenibut. Aegis's expansive NPS offerings are developed to allow providers the ability to more completely identify substance use and afford them the opportunity to provide more informed care and minimize the potential for these unregulated substances to contribute to adverse events, including overdose deaths. In conclusion, Aegis understands the necessity to persistently stay informed and to modify testing of the dynamic environment of designer benzodiazepines and novel psychoactive substances. And with that, I would like to thank you for your attention today. On the screen is the Aegis clinical team. If you have any questions regarding the presentation, please feel free to reach out at the email or phone number shown on the slide. Again, thank you so much, and I hope you have a wonderful day.